the tools in the camera all the time. Now we'll show an example of this. It's in French. So you see these saccades in the movement, and it's because they're trying to keep the tools of the Menti inside, but they're actually also trying to see where this bead has to go. And so the two come into conflict, which leads to these saccades, and eventually zooming out. So we show that the remote view control is not only beneficial because it's dynamic, but also because of the relationship between the needs, the visual needs. So our results complement those of Lanier and colleagues. What you see in this image is a setup where there's a robotic camera that can be controlled by the remote person on the left or by the local person with their hand on the right. And we don't observe differences in time. So both local and remote, both tasks, we don't see differences in time, in task completion time. However, when we look at the amount of movement, so the cumulative movement in meters, we do find some differences. While previous work shows that there is an increase of movement in the remote condition, we see an increase of movement on the local condition. So you see here in the graph. And so what happened is that in Lanier et al.'s study, there's a lot of cognitive effort to move the endoscope as a local person because you have to do the task and move the endoscope. Whereas in our study, the local person doesn't have a cognitive load of figuring out the task. They're instructed on how to do the task, right? And so that's why we see an opposite direction on the effect of the endoscope movement. And that's why we also see this back and forth to previously glanced locations, because only the remote person has the knowledge on how to solve the task, whereas in previous work, both had the knowledge on how to solve the task. Also, another difference is that in previous work, both the local and remote person can see different points of view independently. So the remote person can see one area while the local person sees another area. But in surgery, in laparoscopic surgery, the surgery happens through a monitor, which is here on the right, and the surgeons both see the same view, right? Now, this decrease in management did not result in more opportunities for other types of communications, right? So we already saw that this decrease in management was there, but previous work we did with Helena showed that when there is a decrease in management, there is an increase on other types of communication about the task, right? So you free the verbal channel to communicate about the task. And in our study, we don't see that. Now, this is related to what we saw on the reduction of movement without a difference in time, which is contrary to our expectation, right? But we think that this is because of the effect of the instructional task, and this is our second insight, right? The instructional task that we had, we operationalized expertise by having only the remote person see the colors, so only the remote person could figure out the task, and the local person could only execute the task. So it's a purely instructional task, it's not collaborative. And so the instructions they give is like, move up the endoscope, follow me, grab the bead on top of the cap. We can see that in an example as well. So she says the bead on the top, the one on the right. So they're not talking about the task, they're giving mechanical instructions, right? And now follow me. And so we believe that in these cases of instructional tasks, both modes are sufficient. It's just that remote is more efficient. But we think that for collaborative tasks, this can change, but the benefits remains unclear. On the one side, the division of work has divergent visual needs, so that's better for remote. But on the other side, there's a need for deeper engagement with the content, and then local might have better benefits. But this is for future work. Another insight is that we see learning opportunities for telementoring. The remote endoscope control was a tool to demonstrate how to position the endoscope. In prior work, we see that just showing gaze also is a tool for demonstrating and learning. Now we think that, so to improve common ground and to contribute to the process of shaping the view. And we think that showing the view that the Menti has to achieve is also a way to learn, but that's also for future work. It's also a scaffold for Menti, so P24, which is a Menti, said it's easier when the person who knows where to look is in charge of the placement, so that it's easier, they mean I can figure out other things, right? So you're dividing the workload. It's a scaffolding strategy. And our last insight is about mixed control of the endoscope. P10 said, when I wasn't controlling the endoscope, I didn't have the optimal point of view. I didn't think to ask the mentor for a better angle. So they want to ask the mentor for a better angle, so they want a better angle. And if they have tools to do that themselves, they could just do it. So by having a mixed control strategy, we could take advantage of the fact that the local person has a physical advantage and the remote the knowledge. But we foresee some challenges, such as how to hand off in normal and emergency situations, how to manage conflicts, and the effect of the interpersonal relationship, because in some relationships, people want to say what they want to see, and in other, how they want to see it. That's also a direction for future work. With that, I conclude my talk. Thank you, and I'll see you on the panel.
Thank you very much, Ignacio. Thank you very much. We are going to stay in the field of medical learning and move to the next paper, which is going to be presented by Martin Yaman from the University of North Carolina, Charlotte. And the paper is called Goldilocks Contouring, Enriching One-to-One Medical Apprenticeship with Timely and Diverse Expert Feedback. Please welcome the author.
All right. Good morning, everyone. My name is Mateen Yorman. I'm an assistant professor at University of North Carolina at Charlotte. My presentation today is part of my doctoral work when I completed it at University of California, San Diego. And I'm excited to present this on behalf of all my collaborators, including my advisor, Nadir, who is probably still celebrating Switzerland's win. So the key takeaway of my presentation, and I'm going to start off with this one, is that when we look at the landscape of educational technology, and especially, if you're familiar with the CMU's line of work on intelligent tutoring system, is that a lot of these systems rely on these standalone interfaces that provide salient and targeted feedback. And throughout my work, not just even this and the other types of work that I've done, I found tremendous value with task-embedded interfaces that provide light touch and awareness cueing feedback. And I hope by the end of this presentation, I provide some empirical evidence that this approach can be helpful in a lot of learning interfaces. But to give a little bit of context about this project, it's about contouring and radiotherapy treatment. So very briefly, you first have a patient who's diagnosed with cancer and seeks consultation with a physician. And according to the guidance of the physician, there might be some orders for a number of medical images. So then you end up with perhaps sometimes 400, 500 different types of images, a stack of images that portray a volume of the patient body. Then you have the radiation oncologist who has to go through every single image and delineate the cancerous tissues and the normal healthy tissues. And this then provides the blueprint for high-dose radiation to apply to the patient. What's noteworthy to say in contouring is that there is no gold standard solution. You could have two expert physicians who sit together, look at the same case, and contour things differently. They're looking at the trade-offs between how much radiation you apply at the risk of perhaps destroying the nearby healthy tissues. And then the high-dose radiation is applied. And following up on Ignacio's presentation, this work also is heavily reliant on an apprenticeship model of training, where you have a resident matched with an attending faculty for the duration of the residency program. Contouring is often known as the weakest link in radiotherapy treatments because contouring errors are prevalent and detrimental to patient safety. Latest trial studies show that in some cases, 81% of anal cancer cases had quote-unquote incorrect contours. And in other cases, these mistakes led to a decrease of survival by 22%. So these sobering insights really motivated us to work in this space, and especially when it comes to training and getting the residents to be able to contour better. And throughout some previous works that I've done, for instance, this work that won an award at CHI 2024, we noted some tensions between the learning needs of residents, which are mostly reliant on diverse and real-time feedback, and what the attending faculty can provide. A bunch of different methods, but a lot of them, for instance, in post-hoc contouring, rely on just providing the solution at the end of the contouring session. The faculty usually wear two hats. They are clinicians and teachers, and when time is in short supply, as it usually is with physicians, the clinical work takes priority. So that prompted us to build a system that not only allows the users to be able to contour, but be able to receive feedback. I'm not going to go through all the different components. They all sort of rely on what are the main tasks that go in a contouring, but I'm going to mainly touch on the feedback mechanisms. To first be able to design feedback, we need to have modularized content and basically an architecture that we can use to build the feedback strategies for. And we've been lucky to have partnered with some of our clinicians who've done pioneering work in this space. The C3RO project brought a bunch of different expert physicians together, had them contour a bunch of cases, and provided this wonderful database of different expert contours. We took that data and created two separate contours for it. So first, the consensus contour, which is the weighted intersection of all contours using algorithms like staple. And also the composite contour, which is basically the union of all contours. And these are all expert contours, so they're all valid. And we use that to build three different feedback design mechanisms. The first one is brush. So when a resident is contouring, they select the brush method and they delineate the region that they want to contour. We take the center point of this brush, and if it lies within the consensus contour, the color changes to green. When it's between consensus and composite, it turns to orange. And when it's outside of composite, it turns red. The second design mechanism here is around dots. So once the brush is done and the contour is placed, there are some dots that appear on the contour, and the color scheme follows what I presented in terms of the consensus and the composite contour. And lastly, it's this method that we called arrows and nodes, and that usually is reserved for regions that are very critical to this particular case. So for instance, if the user contour misses a very important region that has to be included in the contour, there is an arrow that points to it. And it's also followed by a short node that appears adjacently to the main contouring interface. This is how it looks like on the interface, and as you might notice, the arrow just points vaguely to the region that should be contoured, but it's not actually displaying the boundaries of the region, and is trying to keep it intentionally a little vague. We also followed this approach for if there was a region that should have not been included as part of the contour, but it is. So these three mechanisms as part of the icon tutor system provided this diverse and real-time feedback that's severely lacking in the apprenticeship model of contouring training. But also more importantly, and perhaps I'm trying to make connections to the key takeaway, they are also very intentionally task-embedded light touch and awareness cueing. At no point we are showing exactly what the contour should look like or the regions that should be exactly avoided, but we're trying to gently guide the residents to the right areas without overwhelming them and as they are completing the contouring task. In a pre-post study with 9 UCSD radiation oncology residents out of a cohort of 10, what we found out when we compared the pre and the post step is that the contouring skill for that particular case, or a similar case, increased by 32%. During the icon tutor session, during the intervention, the residents also pointed to the real-world effect of having icon tutor or similar types of feedback strategies as part of the residency programs. What was very interesting, they saw value with systems like this, not just in the very beginning where they have to learn, but also later on as you're preparing for their faculty positions, because that helps them to get a better, more diverse understanding of the expert contours out there. Perhaps not surprisingly also, during the contouring session of icon tutor, there was an increase of accuracy throughout the session. They receive feedback, they act accordingly to that feedback, and so it increases. But what was interesting was the very initial part where there was a big jump into this accuracy before it sort of tails off. And I have a video of one of the participants here. There's no sound, but this is a 5th-year level resident, and they are performing the contouring. They're getting the feedback as part of the dots. And right about here on the right side, they start sort of poking out and getting those green brushes and poking out and poking out. And this was the case for those participants and a lot of the other ones who participated that led to that big shift in the beginning. They later clarified that they found it very surprising. This is a fifth-year residence, and they mentioned that they completely forgot that they had to include this auxiliary region, this region on the right side, and this tool helps them to guide their attention towards that area. And so what's helpful here is that what helped improve the contouring wasn't necessarily changing the boundaries by a little here and there, but actually being able to point people's attention to areas they never thought of. And throughout my work, I've been referring to this phenomenon as being able to resolve learning blind spots. Sometimes I refer to it as fuzziness, broadly defined as when learners don't know what they don't know. And in this case, is when residents don't know what regions to cover, and through the tool, their attention is guided towards covering that. And that brings us back to this idea of task-embedded light touch and awareness-cueing feedback as part of the key takeaway. And I'll leave you with this. Thank you all so much for your attention. Thank you.
Okay, this week we talked a lot about how to engage clinicians in our work, how to invite clinicians here. And I think it's very exciting that in this session we're going to hear a very different perspective from people who will make a lot of choices on which technology gets implemented in the hospital. And it's going to be presented by Marnisha Anwarachi. And the paper is called Hospital Administrative Perspectives on Integrating Novel Interactive Technology in the Hospital. And this paper also has received a special recognition for clinical impact. So let's congratulate the author of this.
Hi all. So, I'm Vagisha Mangamarachi. I'm a PhD student at the University of Utah, and I'm presenting this work I did with Joshua Dawson and my advisor Jason Misi. Okay, so in HCI, we usually come up with this really cool ideas, especially in healthcare-related research, to help with the patients, the clinicians, and the staff. So to do that, we often do prototyping to test if it actually works as we expected. Then do pilot studies with participants to check whether it actually works in a real live context. But we rarely got to see what happened after the deployment at scale because it can take years to go from ideas to real-world deployment. So, what can we learn when a healthcare technology actually survives beyond the prototyping and pilot stages and become a part of everyday clinical practice? So, the Nielsen Rehabilitation Hospital, or the NRH, is an example of smart technology at scale. To give a brief introduction to what a rehab hospital does, this is where a person who had a serious injury go after the acute care to get specialized medical or therapy services to get ready to their life after that injury. So when it comes to NRH, they give care for many spinal cord injury, brain injury, and stroke patients. To give an idea about the smart technology in this hospital, so we have something called smart patient rooms, or SPR. The SPR provides a way to control the room functionalities through a single app. For example, a patient can control the lights, the blinds, or the TV, or the door using the touch controls, the voice commands, or other accessibility features like sip and puff controllers. So our research group had conducted many research around these smart patient rooms. For example, we have explored the patient experience, patient education, and employee experience with this technology. However, for this work, we wanted to step back and look behind the scenes of the planning, the deployment, and the maintenance. In other words, what does deployment look like from the admin perspective? To answer that question, we conducted 13 semi-structured interviews with the administrators and the managers across the hospital. From this work, we have identified several themes, but in this presentation, I'm only focusing on 2 key lessons. Let's look at the first one. Prototyping was invaluable, but it didn't reveal the realities of a full deployment. To start with the deployment journey, first they began testing smart technology with consumer-grade products in a few patient rooms at the old hospital. As the IT manager said, these pilot studies had helped them understand which technologies worked and which didn't. For example, during this piloting period, they used multiple third-party apps to control the room features. One would control the lights, one would control the blinds, another one would control the media. So sometimes controlling ecosystem can be really harder with multiple apps in an enterprise network. Because of this, they decided to develop a single app which can control all the features seamlessly. Then they built full-size cardboard rooms to understand the room layout and the device placement. Both of these stages help them identify requirements and improve the design. Then they deployed the technology across 75 patient rooms in the new hospital. So prototyping, it was in fact invaluable to go from ideas to deployment. However, not everything can be learned from prototyping. Because of that, the hospital faced many challenges after the deployment. One example is complexity in staffing and training. The hospital had to create new job roles like the IT manager and the health unit coordinators to manage the technical education and troubleshooting. And also, there were additional costs to have an in-house IT team to build and maintain this technology. Another challenge was technical downtime. So we are really dependent on technology. So when it fails, we often get really frustrated. But in a healthcare facility, this could lead to delayed clinical care. Also, there are financial commitments that came only after deployment, like the software and hardware cost and the limited customizability of the vendor products. Also, one nurse admin mentioned that it is really important to prioritize basic hospital needs before budgeting for more new technology. So one lesson is the successful healthcare deployment requires more than designing usable technology. We also need to plan for what happens after that deployment. For example, planning for new staff roles or planning for protocols for technology downtimes, like having manual backup plans. Also budgeting for ongoing maintenance, not just the setup costs. Moving on to the second lesson, the technology became a platform for future innovation. So this is another interesting thing we found. So the hospital admins no longer saw this product as just one single end product. So they started seeing it as a platform for innovation. The IT manager summarizes better. Technology is there, and we can now innovate on top of it. The room became platform for innovation, change, and ideas. For example, this platform gives a way to test new technologies. The hospital has a separate room, we call it demo room, for testing technologies before they are deployed in patient rooms. This allows them to test new ideas without affecting patient care. Also, this supports user-centric design. The SPR application I talked earlier give a way to patient to give real-time feedback. This could be about the technology issues or their overall experience. This continuous feedback process gives them a way to create a more user-centric design in the hospital. The hospital became a place for conducting research and exploring new ideas. Finally, this platform gives the ability to do long-term data analytics. For example, the usage data collected from these smart patient rooms can be helped to understand the value and benefit of long-term investment. So what can we learn from this? The hospital could have just take these smart patient rooms as just one single product, but they created a platform for innovation. Having this technology and work with it every day change how people see this technology. And so, for example, the admins, the clinicians, or the IT staff, so they started asking, what else can we build, or what else can we improve? So the key takeaways, prototyping is important, but to design technology, but there are other factors we need to consider before the deployment. The second lesson is building this type of platform make it easier to innovate and do user-centric design. So thank you so much. You can read all the other findings in my paper. Yeah, thank you so much.
Thank you so much. I am really excited about the discussion afterwards. I think there are many points that we can touch base on, especially when it comes on engaging so many different groups. And so the next presenter, I would say, is an expert on how to recruit clinicians. He will present a study with, wait for it, 62 cardiologists. So I think something we all dream of to accomplish one day. And it is a related contribution from the ACM Conference 2025. And it's called Conformal Prediction for ECG Interpretation, a study on human AI collaboration and clinical decision support. Please welcome Dr. Folgado from Fraunhofer.
Thank you. So, good morning, everyone. I'm Duarte Folgado. I'm a senior researcher at Fraunhofer, Portugal, in Lisbon. And the work that we'll be presenting today is a related contribution that was selected as a spotlight for a long presentation at the Artificial Intelligence in Medicine in 2025. This is a collaboration between Fraunhofer, Portugal, our long-term collaborators from Italy, the Moody Lab, the University of Milano Bicocca, Lorenzo Famiglini, Andrea Campagné, and Federico Cabizza, and our also medical cardiologist, Dr. Elder Dorj, that was also a very important person on the success of this project. So this is actually a project that I really would like to work with, so I'm really glad to be here to sharing this project with you today. So starting in a little bit of motivation, so with the past advances of AI in a more algorithmic perspective over the past few years, we still have to remember and care that we need to understand the interaction between humans and AI. This is an editorial for published in 2022 by Elmer and Lee that emphasize actually these aspects, recommending that the research community to remember that there are complex interactions between a computer's algorithm output and the interpreting physician. While much research is actually being done in the development of AI algorithms, the extent that these algorithms influenced by many types of timings and computer cues still remains unknown. Our work focuses on understanding the interaction between physicians and the decision support systems based on a class of algorithms called conformal predictions. So I have a background on computer science, so I will try to be a little bit introduction to you about conformal predictions, how do they work. So let me explain. Imagine that we have these two images. We have this nice, cute and fluffy dog here on the top, and then we have a more blurry animal that we still can be a little bit unsure what is this. So as a standard AI classifier, usually AI classifiers predict what is called a single class label. So in the first case, the classifier will predict that is a dog, which is correct. But in the second case, due to ambiguity and the noise present on the image, it will incorrectly predict a dog. So conformal predictions work a little bit different. Conformal predictions are an approach that instead of presenting or classifying a single label, they actually present a set of plausible labels. So this is a set of possibilities, and they reflect somehow also the ambiguity and the uncertainty present in the classifier. For instance, in the first image, the classifier is highly certain that is a dog, so the set only has one element. And below, you have also a set that contains multiple elements, and this reflects the uncertainty and the ambiguity present on the model. So we thought that this class of algorithms will work nicely to support the task of electrocardiogram interpretation. ECG interpretation often involves coping with uncertainty, prompting doctors to consider multiple possibilities through the process of differential diagnosis. We aim to answer two research questions on this study. First, how does the type of support for electrocardiogram interpretation, whether single-valued, when I will refer as single-valued is the single, like let's say the traditional way of the classifier predicting, and set value, the conformal prediction one that predicts multiple possibilities. How do they impact diagnostic accuracy independently or when combined with textual explanations? Do case complexity and reader's expertise influence the effects of this type of support and explanations? This was actually our second research question. So we conducted a user study involving 62 cardiologists from various healthcare institutions across Portugal. Participants interacted with an online questionnaire that simulated an explainable AI-based decision support systems that provide textual explanations about its recommendations. The participants' task was to suggest their diagnosis in 20 clinical cases based on the respective ECG traces and the patient details. So we tell participants, we tell cardiologists that we're interacting with a highly sophisticated system, highly sophisticated explainable AI system, but the truth is that we might have tricked them because all the explanations and all the decision support was actually prepared by a senior cardiology. So we follow this Wizard of Oz approach to study the design and be a little bit more focused on this human AI collaboration aspect. To examine the effects of typo support, either the single value and the set value predictions on diagnostic accuracy, participants were randomly divided into two groups according to the type of support they received. Both groups work on the same cases and identical textual explanations. So this is actually the workflow of our questionnaire. So on the first page, participants had what's called the ECG trace and the patient information. And then they were divided in these two groups, like I told you before. And on the first group, they received the recommendation on the set value predictions. That could be a set of possibilities. Here you have a set of 3 examples, but we vary between 2, 3, and sometimes we also have, even the conformal set only had one option. And then we also, they were presented with a single value prediction and also the classifier confidence. So at this page, we retrieve and collected what is called the first decision. So we asked the doctor, what is your diagnosis? And we collected this information. And then the participant moved to the second page. On the second page, they had access to identical information, but they were exposed to the textual explanation of the model that was describing why this decision has been reached by the model. And then we asked again, do you maintain your position? Do you want to change your opinion? And this was called the final decision that we analyzed. So as I said, we recruited 62 cardiologists to balance our data set for the statistical analysis, given some stratifications that we did. We have divided in the 2 different categories, levels of expertise, so experienced less than 10 years in medical cardiology and more than 10 years, the more experienced ones. All right, so let's move to the results. I'll start with the between subject comparison on the 2 groups. So this is only for the first decision, the next set of results that I will show you. So I will guide you to understanding a little bit of these plots. On the x-axis, we have the effect size. In this case, we use the Cohen's d, which measures the magnitude of the difference between the average diagnostic accuracy across participants on the 20 questions. So if this effect size is positive, so to the right, it means that the set value, the conformal predictions, were actually better. They yield to a better outcome, average outcome on the predictions. If the effect size is negative, the single value support was better. So considering all the participants without any stratification here on the bottom, we can see that the mean diagnostic accuracy with the set value support was not inferior to single value support. When we started to analyze also the stratification, we observed that the effect was higher in the less experienced participants, and the for stratification by case complexity, a large effect was observed for the high complexity cases, because from these 20 clinical cases. Some of them were a little bit more complex than the others, and the complexity was rated by the medical cardiologist. So as a first observation, I would like to highlight that the set value support is an effective alternative for conveying advice in the automated ECG interpretation. So set value support can be initially seen as a first-hand, as an incomplete advice, right? Because it doesn't tell like the final option or the only option. But actually we argue that this is actually a process that generates and promotes friction through through under-specification. So it's closely related with the concept of friction in user experience design. Friction incites human deliberation about solving a particular problem by introducing a form of deliberate inefficiency. This helps cardiologists to recall relevant and successful solutions, such as facts or previous cases. So now let's move to the second set of results, the within-subject comparison between between the first and final decision to measure the differences before and after being presented with the explanation. So here we have on panel A a paired plot showing the average diagnostic accuracy of each of the 62 participants. So each dot is actually the mean diagnostic accuracy of each participant on the 20 cases. Some had some had exactly the same average. That's why we don't have 62 circles on the left. On the right, some are on top of the other. We also have on the right the paired mean difference. So I would like to highlight this one because we observed that introducing these textual explanations significantly improved the mean diagnostic accuracy by 3%. The magnitude of the effect was actually similar in both the single and the set value support types. Just also an interesting highlight is that sometimes we design, as AI researchers, we take most of our time doing research on explainability with hopes that actually explainable AI will be better. But in this case, there were circumstances where the doctors were on the first decision, and they were wrong after seeing the explanation. So we call this the white box paradox. So introducing, when we analyze with respect of professional experience and also case complexity, we show that our result case complexity, we only have statistical significance for the higher complexity cases. So explanations did not help on the less experienced ones. Our second finding is that textual explanations improve diagnostic performance on these AI-first systems, regardless of the type of decision support. So from a design perspective, I think an interesting implication is that textual explanations did not appear to provide benefit for lower complexity cases. So for these cases, we will probably not need explainability to reduce also cognitive overloads. So these are just our takeaways. So this was actually the first study exploring human-AI interaction with the set value support in healthcare. Friction introduced by these set value supports leads to a final diagnostic accuracy not inferior to single value, and the explanations in general seem helpful, but they had a null effect on the lower case complexity. So thank you, everyone. We'll see you on the panel or on the coffee break. Thank you.
And specifically, I think you all saw it in the program. It's about delivering blood samples by drones. Something I have not thought of before, but very excited to hear about. And it's called Drones in the Archipelago, Tensions and Technological Progress for Medical Transportation, presented by Mafalda Gamboa from Chalmers University of Technology, University of Porto.
Thank you so much. Yeah, so this paper is not about hospitals, and it's also not about a quantitative study. So this is part of the special issue, and it's the result of a field study on the Gothenburg archipelago in Sweden, which was conducted alongside and together with the Healthcare Region Innovation Office. As a little warning, I am going to play a video with sound, but I will warn you again before I play it. So this paper is investigating the use of drones for transportation of blood samples in the Gothenburg area. And in our case, the Västra Götaland region in Gothenburg had financing for exploring drones as a way of solving some of the issues with transportation in remote areas. And we were invited and welcomed into the project as an external team of researchers. We were not paid by them. To analyze a pilot initiative that they had at a trial to find out if the drones could be a technology used to transport blood samples. And initially they had the dream of also medicine being transported from the islands outside of Gothenburg to the mainland and vice versa. And here you can see how the current system works. It's based on cars and ferries, including there's a peculiar solution where a nurse had to ride a bike from the healthcare center to the ferry to deliver the tests. And this very nurse, she was the inspiration for the project because she had this idea that maybe we could use a small drone to just send them to the ferry and it would solve all of my problem with the bike. So the healthcare regions in general, they're under pressure, we all know this, to improve efficiency while reducing costs. And drones in our context have been presented quite often as a technological solution, but there's not always a focus on how healthcare workers and citizens experience these initiatives. So from our perspective, we needed to first understand properly the ongoing practices before an intervention was proposed. On the screen, you can see news and quotes from the healthcare region's own words, where you see justifications for this project as being able to put more time on patients, but also dreams of changing regulations to the point of being able to deliver directly to homes. You can imagine this was a bit of a wet dream. We, as a research team, were a little bit more cautious because a lot of our previous research on drones had shown that many cases had deep complications with the technology. This is an example that we've seen in literature in Australia, where Google Winx had implemented a delivery system that ultimately got resisted by the community in a quite coordinated effort and got eventually shut down. So while the healthcare purpose in our case gave this a more immediate justification, we were curious how the pilot test would develop. And our objectives were to understand current transportation practices, to examine opportunities and challenges of drone delivery, identify tensions emerging from this implementation. So the study is not really about efficiency, it's looking at how innovation affects existing care practices, relationships, responsibilities, policies, and working conditions for the nurses. So this was a pretty long study, and we adopted a multi-method approach. You can see us there in the goddamn cold of Gothenburg. We did a bunch of interviews, but also citizen study. And the pilot project itself took approximately 3 months, where they did these test flights. So we observed the test flights, but also conducted interviews with the current responsibles for the transport system. Mixed with this, we also looked into the healthcare region reports and policy observations. So we interviewed 13 participants, 5 were central stakeholders, the project leader and development leaders, but also the transport coordinators and also the pilot. And then we also interviewed the healthcare center staff with nurses, operation managers, which are doctors, and assistant and laboratory nurses. So we wanted to understand the entire transportation ecosystem as it was and how the drones were meant to fit into it. I will focus on this presentation on the pilot study itself, but many of our pre-observations were really important to the analysis. Here you can see images to how nurses now handle the blood tests and pack them, and this process involved a lot of different equipment, boxes, documents that they were really knowledgeable about. During the pilot test, the drone used, you can see here, it's a VTOL that could fly beyond visual line of sight. With a somewhat autonomous operation, it still needed a pilot. It had a wingspan of 2.5 meters and weighed 16 kilos and had a payload of about 3 kilograms. The wind tolerance for this one had an average of 14 meters per second, which was really shy of what would have been necessary conditions. It was operated by a private company already running a similar service in Norway. And the pilot project intentionally took place during the winter in the conditions that you can see because the region wanted to test the drone under the most difficult weather possible. So I'm going to play a video with sound now so that you can see what a drone landing is like. So these tests were conducted between January and February. There were 20 planned flight occasions. Only 9 of them were successful. They were never successful when I was there. Maybe I'm the problem, but the main reasons for cancellation were high winds, cloud conditions, or temperatures that reached lower than -10 degrees. So here you see one of the successful flights landing on the island. So in the paper, we show results that we've started into how current practices are, what the impact of the pilot study is, but also what we interpreted in all of this work, paired with our theoretical framings. I'm just going to tell you some of the stories that happened, and I will focus on the more negative attitudes, even though there's a lot of positive attitudes in the paper. You can look at those. We were quite surprised that there was a lot of optimism, even in the citizens, because the citizens of the island seemed to feel quite isolated from the mainland, so any technological improvement or any improvement at all was more than welcome. But looking what there is now, the participants repeatedly described that the system is quite reliable and flexible. The nurses really appreciated that they knew exactly who was responsible when problems occurred. Transport coordinators could adapt schedules when unexpected events happened. And they seemed to not confirm the assumption that the technological replacement was needed. And as the operations manager said, it is now, it is happening. You know, it's a well-oiled machine, and we have control over it. You don't have to think about it. So the participants in general argued that innovation shouldn't automatically replace the systems that already were functioning well. We observed that the healthcare workers valued existing routines, human relationships, and established chains of responsibility. And the current system had evolved over the years to incorporate practical local knowledge, and therefore introducing drones represented a lot of potential lack of capacity to deal with contingencies. So the participants often argue that people are often more resilient than automated systems because they can interpret situations and make contextual decisions. So on this quote, the operation manager said, of course, we always talk about the human error factor, but we talk less often about the human right factor when something goes wrong. If there are humans involved, they can improvise, solve a situation so that the damage is not so severe sometimes, but it always becomes more difficult when we are left to rely on technology. Even the drone pilot himself, that you can see on the picture, became an example of this. Even when the weather data suggested that a flight was possible, he sometimes relied on his own experience and physical feeling of the wind conditions to decide whether or not this was a good situation to fly. So he actually canceled a couple of the flights against what the system was telling that he should do. And this really highlights the value of human judgment and embodied expertise that is quite often overlooked. And this pilot exposed many practical issues. Weather was constantly a challenge, of course, and although the drone was designed for difficult conditions, more than half of the planned flights were cancelled. There was massive challenges in landing locations, safety regulations, wind variability, but also infrastructure requirements and legal framings of how to fly this. And in particular, the healthcare region noted in their documents how it would be very difficult to operate this without massive changes to airspace law. So they found out that they had to do a lot of work. They also found out that they would actually need a 5-meter wingspan drone to cover the need for what they wanted to carry. And there was a lot of variability. So even the nurses in the process of this, they realized, well, if it's going to be a 5-meter wingspan drone, it means I probably have to go outside in icy, slippery winter. And, well, if there's no point of a drone, if I still have to walk half a kilometer to go and leave the samples there. So there was a lot of emphasis on trying to figure out, but one important discussion point that we have in the paper is this idea of technological inevitability. Many participants seem to assume that the drone adoption was a matter of time, and that was not really true. And we argue that this reflects a broader cultural belief that technological progress is always beneficial. And citizens who had not directly observed the drone often imagined a much smoother and simpler system than what was observed in practice. So this was actually a great pilot project because, as the operations manager said, I was present during the test flights, and it is always difficult to imagine until you experience it. It made more noise than I thought it would. So to just leave you with a quote from the citizen study, this study was sparked by the wish to simplify the transportation of blood samples and the possibility of using drones as carriers of this task, hoping to save costs. But while we ultimately challenged the region to reconsider what counts as progress, we actually sort of failed as researchers, and we can talk about that in the panel, on how we should be careful about it. But the project remains unfinished, and there will be a next iteration of it that they're seeking funding for, and I think that they will get it. And the more difficult question is how we can apply our influence as researchers against losing the human expertise, flexibility, trust, and resilience already present in existing systems, and how a techno-positivist stance can sometimes be harmful in this context. And as a citizen pointed out, in our digital time, this becomes yet another solution that makes us more vulnerable. When it comes to sound, society already consists of an all too high noise level. There's a lot of evidence that too much noise affects people negatively. Among other things, the stress level increases. One of the advantages of living in the archipelago is precisely having access to silence. Thank you.
Thank you so much, Mafalda. And you're making my job much easier by already hinting towards the panel discussion. So I want to invite all the speakers, and let's all together invite all the speakers to the panel. And of course, this was a very, very multidisciplinary panel, and I think that's one of these rare occasions where we get very broad views and HCI researchers with a lot of expertise with different stakeholders. So I kind of want to reflect back on the perspectives of the hospital that we have seen today. From surgeons to medical professionals, to drones, to ECG, to what did I forget, administrators, of course. You covered it almost all. I would like to start this panel with a broad question for each one of you, which is about where you see your role as HCI researcher in this complex environment, and how you navigate these tensions with so many different stakeholders. Let me just pass it on. Whoever wants to start a first panel, I'm just going to go in order.
I mean, I can pass it on directly because I closed with that. Yeah, we struggled with this. Because ultimately, in the last reports from the region, we tried to push to the idea that maybe they should report on, maybe we should stop this project. But that was really difficult to get through. And having that always keeping the door open to maybe we should not is really difficult. So yeah, I'm still struggling with when do we know when to stop and how can we advise when it's time to stop. Yeah.
The question reminds me of a conversation I had with a surgeon once. He said, I'm looking forward to the day where I have surgery with an autonomous robot. And I said, I'm not looking forward to the day where a robot performs surgery autonomously. So yeah, when do we stop? And I think that's what we should bring to the conversation, a bit of reality. Now, clinicians sometimes think AI is going to solve everything, blah, blah, blah. And we should be bringing more precise ideas in the design and the capabilities of the technology, perhaps, because there's a lot of buzzwords out there.
Yeah, I would just echo that as well. It's really important to know when to stop, and more broadly, folks who do human-centered work, not everyone recognizes themselves as an HCI researcher. Throughout our work with radiation oncologists, for instance, I saw these two roles, and I think that keeps repeating every time now with a new set of collaborators with the nursing school and the social work school, is that at first we're the ones who sort of bring in these new technologies that we know the space well. So with radiation oncology, for instance, we posed this idea of having VR and virtual reality systems, and they got really excited about it, and they wanted to go all the way through, assign a whole bunch of funding to this. But then later on, throughout that collaboration, we had to be the voice to sort of raise, there are very severe limitations with VR. There is pixel quality is not as good, and that's so much important in contouring. There is fatigue, there's vision challenges. So yeah, I've been sort of seeing like we can be the one to introduce people to new technologies because we understand the space, but we also 100% have to be the voice to tailor expectations and make sure introduction of that technology is according to norms and values of the discipline.
Yeah, I want to answer in two ways. So basically, on the first, so as an AI developer, like I was saying in the talk, so we are developing algorithms with hoping and doing all our validations with numbers, right? And numbers of accuracy, of model accuracy. And what struggles me also with this interaction, struggles in the positive aspect, of course, is that these numbers in the AI community are not the only thing that matters. And I think this work that's we came together actually is an example of that, in the sense that maybe we are trying to do explanations with the hopes that actually are better to the outcome, but sometimes they are not. So we still need to understand a little bit of more the impact and the interaction that yields explanations in the different aspects. The other part is that in a conversation that I had with a cardiologist, they're saying that these LLMs are actually, so they were complaining about the LLMs because patients now go to the appointments about knowing almost everything in the appointment, and they had to battle with the patients that sometimes the LLMs are hallucinating or not giving plausible or factual checks. So this tension between the technology and in the different stakeholders is actually very interesting to see, and challenging. That's some challenges that we have to tackle.
Yeah, so handling tension between the stakeholders, which, so we previously did multiple studies with like patients and talking with like frontline employees, and now this paper about managers. So one thing we learned is that when doing user studies, like getting ideas from all the stakeholders during the designing stage, which really important to know what exactly we wanted to implement in the hospital. And also about having when to stop. So one thing came out during the interviews is that like adding automation into the hospital sometimes could, like having more automation in the hospital would act like a big brother in the like. So yeah, like understanding when to stop is really important, and yeah, and also another thing just came to my mind is. So this is the rehab hospital where I work, right? So these patients have low mobility, and we give them this really accessible like technology where they can use their voice to control the room. So one thing the therapist mentioned is that giving them this much accessibility might work negatively for their rehabilitation, like therapeutic things, because they might not move their hands to control the room, like maybe like turn on the lights, but they might use their voice to control the lights. So that's also like technology. We need to know when to stop and how much technology we might need to give, especially in a rehab hospital. Yeah.
Can I just add a thing to that? I was having a conversation from breakfast about this, about the idea of exnovation. And I think that also, as specialists that we are, right, on understanding the technologies, I feel like there's so much space for us to, we seem to be working on addition only. What else can we bring? What's the new thing that can come? But I think we can become really good or better at seeing what we can remove. So what is there that can be taken away from these systems? What technology are we using now that we can now remove? And these are the types of studies that I wish that we will see a little bit more of. I think it would be quite helpful.
I feel like that's a good moment to open up questions to the audience. Is there any questions? Yes, you have one over there. Hi, yeah, thanks for the talks. I think one question that emerges is maybe rethinking some fundamental ideas, like what is a hospital, right? Especially if data, for instance, or blood samples are not going to be in a singular location, right? We're going to probably need not only new rules about data sharing, but also, like you said, what are we thinking for drones, right? If that becomes normalized. So do you think it's tied to a physical location, or do we need to really rethink the boundaries?
Yeah, the hospital is distributed, so yeah, I agree with you. It's not about the hospital, but it is. When we did the site visits so the hospital has its own logistics department that is outside of the hospital, but they saw themselves very much as the hospital. But it does tend to be neglected. So there is, yeah, of course, there is a more and more distributed site of hospitalness. I don't know if that answers your question, but I do think that we might need to extend the idea of where the borders of the hospital goes, as more as we do a lot of these interventions that do extend it as well. Anybody else?
I'd perhaps add one thing to that, also related to sort of the learning and the educational aspect of it. You know, back to sort of what I presented in terms of these ideas of lightweight and awareness queuing, I'm trying to blend this sort of education and this continuous learning more and more with the clinical practice. And through our work, at least, we've seen a bit of a boundary, and I think that boundary could be lifted a little bit, and that learning could happen. Things change, even the circumstances with the patients change, and so the treatment has to change, but that learning loop is not always complete. So I'm all for, you know, sort of rethinking what hospital means, and at least in this case, bringing, you know, we have an expression in the US, we call it like teaching hospitals, and I think all hospitals should be teaching hospitals to that extent.
Thanks so much for the presentations. I have two very different questions. So one around the project, the hospital administrators project. I don't know if you can answer it, but what's the interaction with insurance? Because I kind of expected that to maybe be a part, and maybe it's in your paper, which I've already downloaded. The other is about the transportation of medical materials and kind of thresholds. So I don't work with blood, but I work with forensic evidence in northern and remote communities. And so I'm really kind of sparking about possibilities about the transport, and so wondered if you could talk a bit more about the stability, etc. You kind of get me.
So the question is like the situation of insurance. It's not something I've explored. It's not a discussion point during our interviews. So it's yeah, it's not in the paper about the insurance. Yeah.
But they didn't limit you, like the innovation or the kind of core design of a smart hospital room in terms of like billing, or something that came up for administrators in terms of adoption as being an obstacle or something we'll work with?
We talked about financial situation in the paper, which the administrator talked about the initial cost, like they planned for all the initial deployment, but there are some more financial commitments that came after the deployment, which they might have not anticipated before. So there were some barriers when it comes to like maintenance, because the technology, we need to upgrade the software, we need to upgrade the hardware, so there's a lot of ongoing cost with the technology. Did I answer your question, or?
Yeah, it's great.
Yeah, do you want to say something?
Okay. So first of all, insurance, it's different in every country, so it would heavily depend on that. But I think that fundamentally they have different values and goals. They want to make money, right? And hospitals care about patients, and so in that sense, I don't see how they would be very aligned into making the hospitals better. Yeah, it's just conflicting goals.
Yeah, I was at the virtual medicine conference at Cedars-Sinai in March. And so we were talking about, in America at least, how the advocacy for charting some of these technology interventions into the standard chart of accounts. I don't know what it's called in the US, I'm Canadian. But that it is like to be mindful of how insurers will kind of work with the technology innovation in health, that sort of thing.
Well, to answer your other question on blood samples, there's things that are not in that paper for various reasons. One of them has to do with what you just asked. One of the solutions that are currently working in the system is that the blood samples are handed to a ferry driver. This is against the law, in theory, but the system has worked, so nobody has said anything. So there's this sort of gray zone handling of what happens. Blood samples in particular, so this was one of the first questions we asked, which is, do they ever get lost? And they told us, yeah, it happens from time to time. But with blood samples, pretty much the only problem that happens is that you'll have to take them again. So this is mostly an inconvenience for the nurses and for the patients, but there's not massive consequences to them being lost somewhere unless you start having worries about the data, which is in the blood samples, but nobody of our participants seem to be concerned whatsoever about the data in those vials. So it is a pretty complicated in-between situation, but because the systems need to work, we go back to what I've seen discussed previously yesterday on dealing with the consequences of some data leaks at the service of a functioning system that is operating in a functional way.
Yeah, forensic evidence gets lost
Exactly.
all the time,
Yeah.
unacceptably.
Yeah, and that's way more problematic than one blood sample because the person is still alive and you usually can just do it again.
Okay, do we have other questions from the audience? Yes, please.
Run, Beatrice, run.
Hi, Jessica Pater, Parkview Help. I found the last quote that the last presentation ended on quite striking. So, and just the whole project in general. So I live in an area where we have very rural populations that we're trying to serve, where a project like this could actually be really important, but we are servicing Amish populations and other cultural populations that might have some tension with these types of integrations. So can you talk a little bit about how you navigated some of the cultural nuances of even getting this project started, and are there other things that have come up from a societal or cultural perspective that you're navigating?
So thank you, I was terrified of this question. So these implementations can work really well for populations that are in dire need of these kinds of things. I would take a leap and say that was not the population we were working with. Those islands are actually populated by quite a rich population. The only thing that was creating was one more slot for blood tests in the morning. It was not really necessary, but they were using it as a test bed for the even more remote areas that perhaps could need it. The problem was that as the project went on, we did find out, and once again, this is not reported in the paper, and I'm sorry, but we did find out that the great majority of what was happening actually seemed to be more of an innovation PR move rather than an actual intention to apply this. And this came through the mouths of many people, including doctors, who said, I think this is a great initiative because it makes us look like we're a progressive healthcare center, and that will attract more doctors to apply to us. So yes, the culture, what is actually behind the project and what's actually behind those implementations is not always the actual thing, but it is a more complex political investment on the image of the hospital or progressiveness in healthcare. I don't know if that answers your question, but in that particular context, yeah, this actually played a massive role, and what's included and not included was guided by that exact problem.
Thanks.
Anybody else on this? Sorry.
Next question. Yes, please.
I was tempted to try shouting there, but I thought I'd come to the mic. Kevin Doherty, University College Dublin. Thanks so much for this great range of talks. As an HSI researcher doing this work with clinical partners, I'm curious if you could share a little bit about your thoughts on what exactly is the role of HCI research in this kind of diverse range of projects? You know, we see a lot of related work in implementation science, public health, and some of this work is sometimes siloed, and we're trying to figure out what exactly is the difference we can make as HCI researchers. I'd just be curious panel's thoughts on that broadly.
I've already said loads, but just you know, to try to HCI researchers are many. We're very different. Our role is going to be very different, and I think we need to understand ourselves and our sensibilities and in our positionings. And yes, mine is usually to say, "Oh, this seems to suck." So yeah, maybe that's mine, but I'm pretty sure that Duarte has a different role as an HCI researcher that he can fulfill, and so on. Yeah, and anybody else?
Yes, absolutely. I think there's an element of reflexiveness with the so-called HCI researcher or the human-centered work, and it is very important to lean into our beliefs and values, and there are many solutions in the domains that we work with, and I think that's very important to understand that. I just wanted to echo it. But I think also, for me at least, and maybe I'm sort of reverting back to the origins of HCI with sort of Norman's view of design and a designer is also we're not the ones like dictating a solution, but perhaps our human-centered work and our technological work and our expertise perhaps in both, but again, that's also depending on what kind of background we have, that allows us to be able to talk to different stakeholders and be able to understand the space that exists, be able to make connections between different domains and siloed projects, from a participatory lens, and ultimately, we're not the decision makers. I never see my role as someone who's making the decision, but as sort of cultivating an environment for decisions to be made collectively with different stakeholders.
So thanks for your question. So I've come a little bit more recently to the HCI, so I've been formal training in computer science, and I've been developing AI algorithms for a long time, and I still continue to do so. But this perspective of trying to understand if an algorithm is really needed, or if it's really the case that an algorithm can have, in theory, good classification, but does it have impact? Is it really being helpful? So I think here the role that we have as a community to understand these impacts is very, very important.
Thank you very much. We have time for one last question. Otherwise, I would really like to touch base on what you've been talking about on the X-innovation, and I think we had that last week as well about non-design applications. So I'd be curious to hear a bit on your thoughts about how we can cultivate an environment where we move towards different kind of contributions, where we encourage people to take different stances and support maybe making supporting decision making at different perspectives. So I'd be curious to hear what your process about finding that has been.
I've been asking around if anybody has written a grant application where the suggested deliverables are not. Yes, great. So did you succeed? Amazing, right? So apparently we can do that. So we need the advice of those of you that have managed to say, actually the outcome is a removal, or the outcome is not doing, or, right? And if these are more explicitly baked into the grant or into the project that's being proposed, then that will open a door for that to be an outcome. So I guess that we can get our minds together, our heads together on how to make that work.
It reminds me of, I don't know if Gina's here, but her response really resonated with me, and I think I think it reverts back to a more fundamental question of what is design, and And a non-design to me is a design. Design to me is an intervention, could be in the form of removal, could be in the form of addition, could be in the form of technological, curriculum-based, completely social. And I think, you know, we go into spaces that something's not working, otherwise there's nothing to work on. And so once we figure out what the intervention is, and we take the delta and before and after, and hopefully it's positive, and if it's not, even there are lessons to be made, then that is design to me. And I think we just have to broaden our perception of design, and we'll be in much better shape as a community.
Thank you very much. I think that's a very great takeaway we can take from the session. Thank you very much for your questions and attendance, and I'm very excited to see how this field moves forward and how we're going to eventually make the hospital better, whatever the hospital will need in the future. Thank you. That's all. Thank you. Such a nice background. You can have one if you want. Yeah, 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 yeah.
Fomos ali só comer qualquer coisa porque elas estavam com fome àqueles.
each slide through, make sure that it's all working. We're going to be viewing it on this small screen.
Great. Está ligado. Ok. Que não fale muito perto, porque eu escuto o assopro.
Ok, claro. É como, exatamente, se for a esta distância, mais ou menos assim, é ótimo. É só também para apontar para a cara, para não estar assim desviado, porque assim o som falta muito mais do que assim.
Apontar para cá. Está ótimo.
Hi. So we are closing the session. I'm very sorry we're going out of conference Interactive Health, but we are super excited to have our keynote speaker, Hugo Campos. Hugo has been a really great voice to hear in healthcare. He has been confronted with issues in accessing healthcare, which I think have triggered in him a strength and a drive to change healthcare for the good, and bringing a lot of these patient perspectives in what it means technology, how technology can help provide or enable patients to have the agency they would aspire to. So without further ado, I will not say anything else so that Hugo can impress us with his thoughts. Thank you, Hugo.
All right. Good morning, and thank you so much, Francisco, for the introduction. And thank you for the invitation. Being here to me is profoundly significant, and I'll tell you the reasons why. Not because being among all of you, but to be here in Portugal, in Porto. I've always wanted to visit. This is my first time, and Portugal is pátria de meus maiores, which means, I suppose, like the poet of Luís de Camões might have said, the land of my ancestors, and a place my family comes from. So thank you for inviting me. I had written an entirely different opening for this, but after sitting with all of you for the last couple of days, I felt that I had to rewrite it. So I blame you guys. It's your fault. But I only added one slide, and it's this slide. This photo wasn't even meant for public consumption. The one, neither one of them. The one on the right was sent for a friend, to a friend. But this is me, and in the yellow shirt there, with at my kitchen table in Oakland, California, near San Francisco, where we live. And this is what I do at least once a month. I'm sorting my dad's medication. We have a box for 31 days, and it takes about a dozen different medications. And every family has a kitchen table like this. It's, I guess, in the U.S., we call it the proverbial kitchen table, right? The place where people have the everyday conversations. And this is ours, and it's where my dad and I sit every day and work out what comes next. He's 96, and he just turned 96 at the end of June. And he's in cognitive decline and has a lot of challenges. And but every decision about his health that we face together, I have to translate it twice. I translate it once to Portuguese, and then translate it once into something that a 96-year-old mind can remember. And healthcare is complex to a point where sometimes even people with advanced degrees get lost in it. As you probably have experienced in your own lives. And this is the table where the real decisions are made, and sitting at this table, there's never been a designer, and not once. And I can say this to all of you, and I feel like I'm comfortable to tell you this in this room, because the past few days I've watched how all of you in this community, you all did something that I almost never see at a health conference. And I saw you guys question your own work in public with a live stream. And yeah, it's brave. And I remember on Monday somebody asked even whether the right design is sometimes non-design. It came up today again, and or perhaps no design at all. It's perhaps better not to intervene. Another presenter said, after presenting her her work and doing amazing work, and she says, I don't have a clear answer. From right here in this stage. And so I wrote down on my notes, I wrote down, multiple times I wrote down the word humility. Right? And so let me ask you with love, and this comes from a good place, where are the designers in my life, right? Where are the designers in my life as a patient and as a caregiver? And it's not for lack of caring, that's obvious to me. So is it a problem of architecture? A problem of healthcare, how healthcare is built and who it's built around? So most of this field, from what I can tell, designs for the institution and calls it designing for the patient. And the institution stands in as my proxy. It's the proxy of the patient. But the institution doesn't do the patient's bidding. So at the end of the day, patients are like that, alone in their kitchen table. Nobody wants to engage with healthcare anyway. Who wants that? Who wants engagement with your provider, with your medication? And nobody wants to be reminded that they're sick. So I'm a fan of an American comedian named George Carlin. Some of you may know him. He's since passed. And he used to do a bit, and it's on the internet, you can look it up. It's interesting, fun, it's funny. This won't be funny though. He had a bit about how we feel like some of us feel like we need to change, we need to fix the world, we need to save the trees, we need to save the bees, we need to save the whales. That's kind of how he said it. And he called it an arrogance because according to George Carlin, we don't even know how to take care of ourselves, right? And we haven't learned how to care for one another. So, and I think he was right to some extent. And so consider this. Maybe patients don't need saving. 2.5 years ago, something finally showed up at this table. And it wasn't a designer. It was generative AI. So what happens next comes down to one word, and to me, what that word is agency, and it's a new kind of agency. AI is giving patients the confidence and the ability to act on our own behalf without asking for permission, and it's changing the game. So I'm a patient, I'm a caregiver. And everything I know about healthcare, I learned inside the American system, and that's the perspective that I bring today. And I ask you to sort of keep that in mind, because it will inform what I tell you. But before we go into it, I want to tell you about the last time that I told this story. And it was about 6 weeks ago, and I was in Seattle. I was at Academy Health Conference. And when I finished, a man walked up to the microphone during the Q&A and introduced himself as a medical doctor from Harvard. And he started by complimenting me, saying that I was very articulate, which sounded exactly how you think it would have sounded. He told me that I was doing the work that I was doing and what I was doing vis-a-vis advocating for patient use of AI was irresponsible, and that AI should be left to the experts. He then asked me 2 questions. He says, where are the boundaries of what patients should be allowed to do, and who takes responsibility for self-management? And I ask you to hold on to these questions. We'll come back to them at the end and revisit them. Now, when somebody asks what a patient should be allowed to do, that's not only a safety question, it is also a power question, right? And mind you, he didn't come up with these questions himself. He was expressing the classic culture of medicine. It's what he was taught to believe. He actually inherited the script, and he inherited from this. This is what you're looking at is the American Medical Association's first code of ethics, 1847, and it tells doctors to unite tenderness with firmness and condescension with authority. Actually, condescension is written into the founding code. It is not a flaw to avoid, it's an instruction to follow. It's a design feature. On the very next page, the same chapter, it says doctors should give reasonable indulgence to the mental imbecility of the sick. Reasonable indulgence. You don't indulge it too much, just some amount. In other words, doctors were instructed to tolerate within limits the impaired judgment, the confusion, and mental weakness of patients. So the compliant patient, the silent patient, the differential patient was never an accident, it was designed in. And the doctor, we're all designing it in every day. We continue to do this. The doctor in Seattle wasn't being arrogant. He was being faithful to a script that was written almost 180 years before he got to the microphone. So today we're building some of the most powerful tools in human history. They will change everything about the world in which we live. And they will not sound like it's 1847. No, they'll sound kinder. They will sound more helpful. They might even sound empathic, right? But being kind, being helpful, and being empathic is not the same as leaving you in charge. So the real question is, will AI inherit the old script from 1847, or will it finally break it? For the last 2.5 years, all the conversation about AI in healthcare has been about what it can do for doctors, what it can do for hospitals, and what it can do for health systems. But something remarkable is happening right now, and it's patients. Patients using AI with skill and with agency in a way that's changing what it means to be a patient. We are taking control of our health narratives and turning AI into a tool for liberation. And most of healthcare hasn't yet caught up with what patients are doing. When folks look at patient use of AI, all they see is fear. All they see is worry that patients will hurt themselves. So the conversation tends to always land on the same words. It's about keeping people safe, or it's about building trust. But where we see agency, they see risk. And the question, I think, worth asking is risk according to whom? To quote fellow advocate Sue Sheridan of Patients for Patient Safety, she says, she just said this early this year, while doctors adopt AI at the speed of trust, patients adopt it at the speed of desperation. So what Sue means here is that when you're diagnosed with a life-threatening condition and when you need to understand complexity, or when you are in pain and the system is not available to you, AI may be all you have. Right? And I think what's being missed here is that AI is now allowing patients to do things far beyond simply using a chatbot. The research conversation is only starting to catch up with what many patients are already doing. And that's, I suppose, good news, but I kind of wish that we were further ahead understanding this phenomenon. So let me show you a little bit how far we've come in just a couple of years. And you may remember ChatGPT, I think 3.5 was released to the public in November 2023, I think. So about 2 years ago, when we talked about sophisticated use of AI by patients, it meant that perhaps the patient was uploading a lab result or an after-visit summary to a chatbot for a one-off read. Today, patients are building entire project notebooks. Folks are building custom skills, as I have done myself, that run analysis across dozens of documents through a lens that they define. And that is the shift from asking a chatbot to unleashing agents at a problem. A few things about me before we sort of go much deeper into this. I live with hypertrophic cardiomyopathy. That's a relatively common type of genetic heart muscle disease, and puts people at sudden risk for sudden cardiac arrest. I'm one such lucky person, and that means I have an implantable defibrillator. I'm on my third device. I've had these devices for 18 and a half years. I'm also the care advocate for my dad, 96 years old, who lives with my husband and with me and has a number of complex health issues. And to make matters more exciting, is also a world-class contrarian. And I'm a patient advocate. I'm a partner in research. I'm part of the NIH All of Us research program. I'm part of the Nutrition for Precision Health study. Runs on top of the All of Us and a bunch of other PCORI-funded studies and a bunch of other things. But that's not why I'm here today. I'm here because I've used generative AI for my health and my father's health nearly every day for the last 3.5 years. So everything I'm about to tell you comes from my lived experience. Not theory. I don't do this work alone, so a lot of it comes from the work that I've done with fellow advocate Liz Salmi, and Liz is not only a friend, she's a brain cancer patient. She is a researcher at Beth Israel Deaconess and Harvard Medical School, in addition to being a fierce advocate, an incredible person. And late last year, we published our views in Non-Perspectives. It's the journal of the National Academy of Medicine. And there are two ideas from that paper that carry this whole talk, and I want to call them out to you so you pay attention to it. Number one is the difference between what we call institutional AI versus patient-directed AI, carefully worded, patient-directed AI, and I think we call algorithmic resistance, and I'll get to both. So when I say AI, I'm not talking about one AI. As a patient or as a caregiver, from where I stand, there isn't just one AI, there are two. One works for the institution, the other works for you. Right? Institutional AI is deployed by health systems, it's deployed by payers, it's deployed by vendors, it's there to standardize workflows, it's there to manage risk, it's there to optimize for revenue, and it's not there to prioritize your values or prioritize your journey. It's a margin over mission. You guys may have heard this before. Institutional efficiency and risk often come before patient values. And oftentimes doctors don't even choose these tools. They are assigned to them by the institution, mostly for compliance and for other institutional goals. And I'm not talking about just the scribes or the ambient AI that listens to your visit and capture notes. I'm actually talking about the AI that shapes who gets care, who gets discharged, which medication gets approved, all of it running quietly in the background, shaping our care whether we know it or not. A lot of times folks don't even know how some of the decisions were made, and they were made by predictive AI or some other algorithm. And here's the part that trips people up. Some of this AI is pointed right at you. It's in the portal. It's the chatbot on the health system's website. It's a lot of the work that you guys are developing. It's patient-facing. But if it's patient-facing, it doesn't necessarily mean that it's patient-aligned. And it certainly doesn't mean that it's patient-directed. An AI that faces you is not necessarily an AI that works for you. Now, patient-directed AI is the opposite. The patient chooses the tool, the patient steers it. It lives entirely outside of the rules of the health system. You may not even, if you don't ask the right questions, you may not even notice it. We can use it to understand a diagnosis, research a treatment. We can use it to ask the weird what-if questions and back the decisions that are right for us, not the decisions that are most convenient for the health system. So the same technology in the hands of doctors or in the hands of patients can be either the lock or the key. And I've talked to some of the folks here yesterday over the break about how AI for the institution, it constrains, and in the hands of patients, it liberates. The difference comes down to who is in control, who deployed the AI, and for what purpose. And if you think that generative AI tools built for medicine are smarter than those being used by patients because they are built on medical literature, or perhaps they have access to the New England Journal of Medicine or the JAMA network, and they are pitched to clinicians as the safe alternative. Think again. A study that was published last month in Nature Medicine tested this assumption, and it seems to not be holding. And researchers from NYU, and I know there are folks here from NYU, they put the two best known clinical tools, Open Evidence and up-to-date Expert AI, up against the frontier models that the rest of us are using. That's GPT and Gemini, Claude, etc. And the general purpose frontier models outperformed specialized clinical tools across all benchmarks. And think about this. According to the study on the benchmark built from real clinical questions, the specialized clinical tools landed in the same tier as a free Google search summary. So some of the most capable medical reasoning tools available today seem to be the ones that are already in our hands. The good news is that this is the worst AI that we'll ever have. It will continue to improve. And I want to draw your attention to something else here, because I know how important human-centered design is for all of you, and I lost count of how many times I heard the term patient-centered. And it's fine. I don't have a problem with patient-centeredness. It sounds fine, but it's a kind of a catch-all term. I think we may have to retire it, because it's not really, it's broad enough to be kind of, to some extent, kind of useless. And so, you know, and I get that we may be well-intentioned as we try to make AI more accurate, safer, and more efficient, even empathic, but none of that tells us whose side it's on. The question that matters, that should matter to us first is, and that's kind of how I like to think about it, is whether the AI expands or constrains agency, my agency. In other words, does it help people act on their own behalf, or does it keep them managed? So you can test this with 3 questions. You can ask, is the AI pointed at me or at you, at the patient? Does it serve you? Do you steer it? And so let me give you 3 terms that actually do mean something. Patient-facing, patient-aligned, and patient-directed. So if the AI is patient-facing, it may be pointed at you, and that's a term that also came up yesterday and the day before. But it says nothing about whose interests it serves. Patient-aligned, I suppose, is a little better. Perhaps the AI prioritizes patients, but it can also be designed to answer to other stakeholders, which is usually the case, and you still don't steer it. Patient-directed is the one that gets a yes across all 3. It points at you, it serves you, and you steer it. That's the one that I care most about, and I care most about it because it has, because it broadens my capacity to understand. It's because it helps me decide and act. In other words, it's potentially liberatory. When I was a kid, we had a family doctor who came to our house whenever my mom called. And back then, medicine revolved around the doctor-patient relationship, the doctor-patient dyad. That's another word that I heard, I think, yesterday. The doctor had the knowledge, the tools, the authority, and the patient had the story, the symptoms, and the need. And it was a tight partnership. And over the years, this has been dissolving. For the last couple of years, everyone has been talking about the triad. And I was a couple of meetings in Washington, D.C. this year. And I wish I had a dime for every time I heard the triad. And I was on the bandwagon as well, and for a while. But the problem I have with this is that it assumes that the AI in the room is neutral, that it's shared, and that it serves both doctor and patient. And it does not. The AI in the room answers first to whoever deployed it. Doctors actually bring their own tools that the institution handed them, and now patients are bringing their own. I bring my own recording device, my own AI, into every meeting. So it's not really a triad. It's two sides of the table, each with their own AI, each serving a different master. Somebody said a tetrad, but I think it starts getting a little complicated. And in my view, the patient side of the table is not really a hazard to be managed. It is an opportunity for all of you. It's an opportunity to design for. Thankfully, more and more patients are using it well. I often remind fellow patients and advocates that AI confabulates. I'm not saying hallucinates, because it's really more of a confabulation than anything else. And it confabulates with confidence, and it can be flat wrong sometimes and still sound completely sure of itself. Par for the course. So fluency is not accuracy. And I remind people, don't think of AI as an oracle. It is not an answer machine, so don't use it as such. Think of it as a thinking partner that you direct. It's not an oracle that you obey. And that isn't, I don't even think it's of it as a limitation. I think it's the whole point. Medicine is scientific, but its outputs are probabilistic, not deterministic, which means context matters. My dad was in hospice care 2 years ago. So much for that prediction. So, so context matters. And because context matters, the patient is not a passive data source. The patient is a source of meaning, a source of memory, values, lived experience, and above all, context that nobody else has. And it's constantly being upgraded. And I always have new context that my providers don't have. So a tool that helps patients ask better questions fits well with how medicine actually works. And when the patient directs the tool, it puts the patient in charge. That's the real shift, from getting better answers to asking better questions. And this attitude takes a new kind of health literacy. Too often, health literacy gets reduced to compliance. I have a friend who's a doctor, and I promised myself I wouldn't digress so that we stay on track, but I can't help myself. And it would be brief. And he says, no, it's not. Health literacy is not for compliance. We really are trying to help. And I get that. I get the sentiment. I'm not trying to be overly critical. But it's about this. It's about read the pamphlet, sign the form, follow the plan. We know we're the experts. You just do as we say. It's a type of uncritical health literacy, knowing just enough to follow instructions. They want that. It's know enough to follow instructions, but not enough to question them. AI is the first tool that patients have had that can actually help them do these things in real time. Question, challenge, act, and that is the point of friction that we keep hearing all the time. The patient is bringing the printout from the AI to it's challenging my authority as a physician. Maybe we all need a little challenging. Challenging is not good, makes us think. So, but even now, when I hear folks talk about the need to teach patients to use AI safely and effectively, I often think safe and effective according to whom? Who determines what is safe and effective for me, for you? Do you want me to tell you what I think is safe and effective? It's about knowing how to use AI to read the system, not just the output. So who holds the power in your care? When does the system serve itself instead of you? And what do you do when, with what you find? So in practical terms, it's about knowing where your data lives. And I forgot to move the slide. I talk to folks usually in these three different sort of buckets. So think of it, fellow patients, I say, think of it in these sort of three buckets. Knowing where your data lives, what's missing and how to get it. Every one of us now has to be a bit of a citizen informatician, understanding data formats, how much data is too much, how much is not enough for the project or the inquiry. So it's also about knowing which tool fits the job. Should I use a notebook, like say, for example, Notebook LM or something like this, to work through multiple sources? Or should I use a coding agent to build or debug something? Or perhaps I should use an audio overview to help explain a complex concept in a conversational format. Or maybe just a general purpose AI assistant is enough to help me reason through the problem. And finally, the third bucket is kind of underneath all of it. It's really about asking one question. Who is the AI really serving? Who deploys it? And for what purpose? So it's preserving your agency. I get why people are fearful. Things are moving really fast, and that can be very unsettling. And I don't think fear is wrong. It's a useful signal. But we can't stop there, and asking who the AI really serves is what stands between us being informed and being, I suppose, manipulated, for lack of a better word. And that flip from fear to agency has a name, and we're calling it algorithmic resistance, and that's the deliberate and informed use of AI to push back when the system's priorities are in conflict with yours. I'm not anti-technology, I'm not anti-AI, I'm pro-agency. And it's a move that we can all make ourselves and help others make. So I'll give you a couple of examples. This is something that happened 2 years ago. My father developed a severe rash. And this is after he was discharged from hospice. The dermatology appointment was 4 months out, and we couldn't wait. We saw the primary care doctor, and she referred us to, didn't make a diagnosis, referred us to dermatology. I scheduled the appointment 4 months out. 4, not 4 weeks or 4 days, 4 months. So, and we were happy waiting, except that one morning I brought his breakfast, and he says to me, I can't live like, he was up. He hadn't slept all night. And he says to me, I can't live like this. I scratch myself all night. It's horrible. You have to do something. And I said, Dad, we have an appointment. We're waiting. And he says, no, I can't. So I said, okay, I'll see if I can look it up on AI or look it up on Google. I actually looked up on Google first. I took pictures of the rash, but I couldn't make heads from I couldn't figure out what it was by just looking at photos. So what I decided to do is I put the photos in various different large language models. I uploaded clinical notes from the visit with the primary care, because obviously the AI couldn't see the patient, but the PCP did. And then she wrote down what she saw. So I uploaded the clinical notes, his after-visit summary for the objective data, and his labs. And I asked the AI to produce a table with differential diagnosis. And I asked the AI, give it to me in order of likelihood, and 3 columns, give me the diagnosis on the first column, and give me the rationale on the second column, because I don't trust the AI. I don't trust anything. And so I figured I need to see why it thinks it's that. But actually, I didn't even care what the diagnosis was. What I wanted was the third column, which is the intervention. And my thinking was, if there are 2 or 3 of these diagnoses that have the same intervention, we're just seeking relief. And so I'll just go for the intervention. I don't care what, I don't need to. So if you pay attention to this, this is from the point of view of the patient, my goal is completely different. The doctor wouldn't do anything without the diagnosis. They need a billing code. I'm not billing, I just need relief. So the AI was the only one that surfaced a plausible connection between the rash and the chronic kidney disease. So that is chronic kidney disease, now stage 4. And the PC primary care doctor didn't raise that as a possibility. And when I brought it up to the dermatologist, she seemed alarmed, and she says, "Oh, is he on dialysis?" And I said, "No, he's not on dialysis." At that time, he was stage 3. And the point is that I said, "Don't you have the blood test results?" And she says, "No." And this is after in the U.S. we spent billions of dollars with meaningful use interoperability, billions and billions of dollars. And it's 2 doctors in the same county don't have access to the same blood test. 2006, we're 25 years into the 21st century. We've lived a quarter of it already. And so, we're not even setting up our doctors to win. The poor dermatologist doesn't even have the tools that she needs in order to make an informed decision. I'm sitting with a large language model. I'm better equipped. So, sad state of things. So we made some low-risk changes with my dad. We switched with his agreement to a vegan diet, and we switched to lukewarm showers every other day instead of hot showers every day. And within 10 days, the rash cleared, months before we saw the dermatologist. When we saw the dermatologist, he was way into the picture on the right. So now for the bigger one, I'm a Kaiser Permanente member, and it's a health system in the U.S. If you're not familiar with it, has about 13 million members. And I wanted to download my health data in a format that I could feed, as I sometimes call it, my large language monsters. And so I had, I wanted, I was tired of uploading these large PDFs, and sometimes the AI wouldn't see certain things and just miss, and it was hard to, it was clunky, difficult, terrible, and it was like, oh, I wish I could have an XML file or a text file or a JSON, something that was more usable. And 2 people had already built open source tools for exactly this. Somebody had built, Josh Mandel of Microsoft, who's both a software engineer and a medical doctor, brilliant person, had built a Smart on Fire app called Health Skills. And somebody else had built another tool called Open Record, went about this, doing the same thing, pulling up the record, but through using an MCP server, just a different method. And both designed to work with Epic, EHR. And I thought, this is great. Kaiser has Epic, and so that's going to work. And both are free, and neither worked with Kaiser. Turns out Kaiser has a unique implementation of Epic that doesn't work with any of these things. And so I figured, that's a bummer. I was really disappointed. And but I'm not a coder. I'm not a software engineer. I'm not a medical doctor. I don't know. I'm just trying to figure this stuff out. And so I got on Claude, and I dropped in a link to one of the projects, and I asked a simple question. I said, would this work for me? One of these? And can I just change one line? Would that work? I don't know. Help me. And I wasn't asking the AI to build anything for me, but the AI, Claude, reframed the problem, and it offered something that I hadn't thought to ask for. It gave me a starting point to build from. So it basically asked, do you want me to sketch a minimal Kaiser scrape? This is exactly what it asked me. It asked me, do you want, this is verbatim, do you want me to sketch a minimal Kaiser scraper scaffolding we would need to start? I had no idea what that meant. I was like, I don't know what a scaffolding is. What a bummer. I think I know what a scraper is because I've seen people scrape data from the web. I know that, but I don't know scaffolding. But what do I have to lose? I said, okay, yes. 2 weeks later, I had a working open source set of tools on GitHub. It's there. You can download it, you can view it, you can use it. Pulling my meds, pulling my labs, messages. It sends messages, orders medication. And I can see my visit notes. I can ask any question I want in plain English or Portuguese. And it has a name. I called it OpenKP. And again, I don't write code. I didn't even know what an MCP server was when I started this. I didn't even know how to use GitHub. What's a repo? I don't know these things. And so help me. What do I do? How do I host this? Oh, go host it here. And so Claude did everything for me. It wrote the code. It pushed it to GitHub. and it helped me deploy it. And of course, I didn't trust Claude alone. I put Codex on the case just to make sure Claude was working right. So what I did was deploy a coding agent on a problem that I had. And for my favorite part, somebody has already forked it, and they are running it on Windows, and they contacted me, and they said, yeah, this is great. I'm not a coder. This is amazing that it works. I said, I'm amazed that it works. And so another patient. And I said, can you document, ask Claude to document what the changes are on Windows so we can update the repo so that others, on GitHub, so that others know. So it's documented. And it did. Sent me an MD file, and actually, I think I had my AI put it there. Anyway, so it's no longer one patient's hobby anymore. It's really a tool that other people are picking up and making their own. So, and here's the kind of question that a portal will never be designed to answer. Even if you are working on a project, I doubt that the powers would allow you to put this kinds of functionality. So here's a question. Read every visit note from the last 2 years. Find every time I raised a concern, I asked a question, or pushed back, how was it documented? Look for patterns in how my engagement gets characterized. The answer is quite fascinating. So we're not really talking about having a prettier lab display, although you can do that too pretty well, can even build a site. But what you see here is agency over how I appear in the chart. It lets me see not just my data, but how the system sees me. That's an entirely different category of tool. And what's important is this: I am not a developer who built a tool. I'm a patient who directed an agentic AI to build a tool that I needed because the system or nobody had designed it for me. And notice the direction that we're heading. The JAMA paper that you see there on the screen names the risk, and the risk is the risk of de-skilling. That seems to be happening to some scale. When doctors rely on AI too much, they lose skills that they already have. But I never went to med school, and I'm not proud of that, but I wish I had. But I don't have the skills to lose, and so I only have. For me, I'm getting upskilled. And so the opposite is happening with patients. Patients are upskilling, directing AI to build the very access points that the institutions won't give us. Which then brings me to the barrier that we face now, and it used to be technical literacy. And many of you here remember the Night Scout project, type 1 diabetes in 2013 or so, or 14. And this is it became a movement called the We Are Not Waiting movement. And I think the hashtag is still around, created by Howard Look of tidepool.org. And many others, Dana Lewis, John Kostick, Ben West. But these are all type 1 diabetes patients who were also coders. They were people, and this was the barrier. I couldn't do that, and I watched in amazement and excitement when that was happening with the We're Not Waiting movement, because I wanted to do the same for my implantable device, but I didn't have the skills, and I didn't have a community like that, and they did. But that was back then. That was a barrier. Now it's not that anymore. Now the bar for technical literacy is much lower, as you can see. So coding is really not to the level of being able to build things like the things that I'm building. It's no longer the same barrier. So now the barrier is cost. So a $20 a month plan goes through its limits really fast, and I now am on plans that cost $100 to $200 a month for OpenAI to use Codex and to use Claude Code. And can run into thousands of dollars. Oftentimes, depending on what I'm doing, I bump against the limits, and I have to put in credits, right? So the divide is shifting, and it's no longer who can code, it's who can afford these tools. It's a patient. If we think of patient-directed AI in order to become a thing, If it ends depending on frontier model subscriptions, then we are rebuilding some of the same old inequities in a new form, and that would be not good. So that's a problem that not everyone can solve on their own. So let me go back to that doctor at the microphone at the Academy Health meeting 6 weeks ago. He said, leave it to the experts. And I've heard this from many others. A lot of folks keep saying this, don't touch it. Just leave it to us, the experts. And this is exactly what patients are being told to do, stay out of it, trust the system. But the experts are telling us this while institutional AI is actively being deployed on them, on patients, right? Sometimes even without their knowledge. So it's kind of funny, huh? It's like, no, stay away from it. Let us deploy it on you. And it raises the question that really matters to me whenever I come across AI. And I try to ask, is this a tool for me or a tool on me? And we have to be honest about that. The doctor's first question was about boundaries. He says, where's the line on what a patient should be allowed to do? And my answer to that was that train has left the station. We're not asking for permission. Thank you, but no thanks. And we're not asking permission. Patients are doing this, and we're doing it at scale. The question isn't whether we allow it, it's whether we help people do it well. And I think for you guys in this room, for all of you, it's a literacy question, it's a design question, it's a literacy question and an equity question all at once. The doctor's second question was about accountability. He says, who is responsible when something goes wrong? And I told him, of course, I'm responsible for my choices. Patients are not children. I suppose some are, but not in that room. And I asked him, who is responsible for a broken system when I can't get my 96-year-old father an appointment for 4 months while he suffers and can't sleep? And so who's responsible? Oh, that's another problem. Yeah, it is another problem. I have to solve the problems I have with the tools that are available to me. We agree to disagree, and I think the good news is that I suppose folks got to see two very different views. Now, here's one thing that neither one of us can argue with, and this is already happening at scale without permission. And this is a 2026 Gallup survey that found that 14 million American adults skipped a provider visit after using AI. That doesn't mean that every decision was wise. There are probably a lot of unwise decisions. What it means, though, is that this is already happening. It's a sign of agency. People are already using AI to make decisions that used to require a gatekeeper. And that's 14 million people who were afraid or perhaps desperate and did not have their problem resolved by simply trusting the system. And that's agency at scale. So the opposite of fear isn't trust, it's agency. So let me be honest about the limits of my own story. Everything that I told you is about me, and I'm one patient with the time and the skills and perhaps the resources to do this. And my instinct always tends to run on individual autonomy, self-determination. It's kind of my bias, so it's there for you. It's kind of how I think. But I have a good friend and a colleague in computational precision health. He calls me out on that all the time, and he's right to do that. Because I think the harder question isn't how I free myself. I think the harder question is how do we put this power in the hands of communities who have never had the AI work for them. And I'm talking poor communities, rare disease communities, indigenous communities. How do we put power in the hands of folks who need to solve their own problems? So I don't have the answer to that, but I think it should be the most important question for us. Which I suppose is exactly where you come in. I'll end on something personal. I was born in Brazil, and I grew up in a house full of books. My mother was a teacher, and some of her books were written by a Brazilian educator named Paulo Freire. And he wrote a book called The Pedagogy of the Oppressed, A Pedagogia do Oprimido, and in exile in 1967, 68. while Brazil lived through a dictatorship. So the books on my mother's shelves weren't really books about teaching. They were subversive ideas that unsettled people in power. And it unsettled them, I suppose, those people, because that is what, I suppose, power fears. It fears when those it kept dependent learn to read for themselves. Before my mom passed away, she asked me if I wanted her pedagogy books. Some of them were original prints, and I said no. I'm not a teacher. I said, what am I going to do with pedagogy books? And I regret that deeply. And I've really never been that more wrong. So, because Freire wasn't really writing about classrooms, he was writing about power. And he argued that education is never neutral. It either teaches people to accept the world as it is, or it becomes the practice of freedom. I'm not saying that medicine is a dictatorship, and it's not my argument, but Freire gave us a language for power, and I think to some extent medicine has its own power structure. It has experts, rules, gatekeepers, and has patients. And Freire had a name for this, and he called the banking model of education, experts depositing knowledge into a silent person, told to sit still, take it in, question nothing, push back on nothing. It's in good hands, right? Medicine runs on the same model. The expert deposits and the patient receives. It remembers, the patient complies. But patients aren't really empty accounts. We bring memory, we bring context, we bring values, and we are the ones who live with the consequences. Paulo Freire taught the poor to read so they could read the world that kept them poor. And what you saw today, and what you're witnessing, I suppose, is a patient learning to read the system that reads him. And AI can help with that. I think not just any AI, perhaps patient-directed AI. Still, there's no guarantee of liberation. The same technology can make patients more compliant or more measurable or more manageable. Or it can help us question or understand and act on our own behalf. The technology does not choose, we choose, right? So as we wrap up here, I suppose I urge you to build AI tools that patients direct, not AI tools that direct patients. Right? So it's AI as liberation technology. I have a copy of the slides there for you on that link, and all the resources that I mentioned today are in that link in that subdomain. Thank you for your time and your attention.
Thank you so much, Hugo. We can go sit there.
Thank you. Let me get a word.
Yes. So we'll be taking questions from the audience using the same website that Jason had for the steering committee discussion. So please scan it and start putting in your questions, please. Thank you very much, Hugo. This is really inspiring and thought-provoking. And we did talk about this with Hugo. We thought that it was important to be critical, because we thought that critic is the highest form of love for academics, and we thought we should practice it with our work as well. And I would start by asking you a question, Hugo, that having thought a bit about this topic, we think it would be interesting to share, because this community has been on the forefront of creating approaches to involve people in the design of the technologies. In the beginning, much about creating possibilities for people to be in charge, to negotiate agency with employers that were wanting to exploit them a bit more. So it was understood that if it was possible for people to take a role in the design of the technology, it would be able for them not to be so much controlled by their companies where they would be working, by the factories. So it's thought of as a way of liberation through the agency of others, because patients would not have a role. And maybe my question to you, and I know that this is probably not the easiest question because you're not a researcher in this area, so you would have to articulate, but I would ask you if you think there is a role for approaches like the ones we have been employing that start to or try to engage people in this design, so that or whether we just have to change the ship to be able to building tools for patients to direct it themselves.
Thank you, Francisco. I feel it's a little unfair for me to come here and tell you all this and not have a solution that I can give you. But the truth is that I don't. And what I think is the designers have the skills and the ability to better the world, to better the human experience. There are as we go through solving the healthcare problems that we encounter along the way. So it's more about who's solving this for us, and what are the motivations? And I realize that designers are they're working within constraints. There are always design constraints. There are limitations, goals. They are not necessarily being set by the designers, right? And so you're designing for a particular objective, and so so it may be unfair to ask you to bring some of these biases, I suppose, or inclinations into the work when you're not being measured and judged by those measures, right? So I wish designers were doing things on their own and not working for the health system, but everybody has to pay rent and pay mortgage, and the realities of the world are different realities, right? We all have to sometimes do things that are not quite exactly how we would do them, just because we have to. But I wish there, maybe it's I don't know, a collective of designers, maybe it's this group, who can, maybe it's Fraunhofer, so to do these explorations that are sort of devoid of the boss, that are purely altruistic in a sense of empowering people to, maybe it's the designers teaching patients how to design, and so how do you get that? So how do you provide the tools of some of the design tools in the hands of patients? I don't know. I'm sorry, it's a evasive answer.
So I'm going to read one online questions. One, I think that right now the top question is, everyone agrees health system has serious problems, but the technology ecosystem, we don't know if it's better, right? What do you think about sort of the big tech companies like OpenAI, Google, and Anthropic? Are they interested in liberating the users, and what do you think their roles in this?
Yeah, thank you for that. I don't mean to say that, like I said, I'm for agency. I'm not necessarily for AI. AI is an incredibly powerful tool. So again, to sort of bring back to Sue Sheridan's quote, patients said, it's really a balance between trust and desperation, right? It depends on, somebody may say, you know, it's, are you comfortable putting your information, you're sharing your medical record, your enormous JSON file with everything about you with a company like OpenAI perhaps, or Anthropic or Google? And I said, well, I wish I didn't have to. But if I have to wait 4 months for an appointment, and if the system isn't there for me, so we really have to ask the question we should be asking is, why do people do this? It's not really, are you comfortable with doing this? It's like, why do I have to do this? So it's absurd, right? So it's like we have to, if we all collectively agree, and I'm in agreement, I don't disagree. That we don't want to, that we want to protect our privacy, that we don't want to share our I think it's a perfectly reasonable and valid concern. So we have to figure out what are the solutions. Maybe it's large language models that we run on our local, maybe it's community-driven large language models that are deployed by the community. I don't know how effective that would be to protect our privacy, but perhaps a step in the right direction. So there are ways around it. We just got to be creative. And what I think is not productive is to say, no, I don't want to be involved in this, because you'll be left behind.
The next question that comes has to do with the risks of these technologies that have often led people either to commit suicide or to have nefarious consequences for themselves. And many times they had to do with this, as you said, confabulations that seem really authoritative and correct. How do you see the design of the technology maybe being different so that this is not so much the case? Because we know that it will never be a perfect solution, but are there things through your experience that you think would help making sure that these interactions would not result in the same risks?
Yeah, this is a tough question too. Of course, we don't want people to be harmed, especially seriously harm or be led to a point of desperation where they harm themselves. Of course, nobody wants that. And it is, I think it's a combination of things. It's looking at the technology. It's also putting some curbs, perhaps, say, for example, in case of children. Maybe children, we don't let children drive. And maybe we should protect children from using technology that can be harmful to them in the same way that would protect children from using illicit drugs or anything that may be harmful to their life. So I think what's very scary at the moment is that everything is moving really fast, and we have a lot to figure out, and very quickly. But I think having these conversations, I think, are important for us to really understand what's at stake and what makes sense for all of us in terms of preserving our privacy, preserving our ability to live life in the way that we wish to live our lives, according to our values and our preferences. And it is a tool that's there, and so we need to figure out how to navigate it. That's kind of a non-answer. Huh? I'm sorry. Yeah.
Okay, I think you sort of answered the top two questions that we had. We can take some questions from the audience. So the SVs has microphone. So if anyone wants this one.
Hi, I'm Navina. I'm a faculty at Georgia Tech. I thank you for this very inspiring and powerful talk. So just to explain where my question's coming from, so some of my research looks at healthcare governance in hospitals from the perspective of healthcare worker labor unions. And I was struck by the parts of your presentation that talk about kind of the hierarchies between worker and patient expertise. And
I don't see you. I'm so sorry.
Oh, sorry.
Oh, wave. Oh, yeah. Okay, I'm sorry. Now I see you. Good, yeah.
So right, the hierarchy is between worker and patient expertise. I'm curious if you think worker-patient solidarity is possible, and maybe what opportunities do you see for that solidarity to kind of strengthen and maybe address some of the issues with the lack of attention to certain kinds of design you've been talking about?
I'm sorry, I don't think I comprehend the question. So what do you mean by solidarity?
So healthcare labor unions sometimes work with patient advocacy organizations to develop certain advocacy goals. Yeah, that is, in what ways, I guess, could we leverage that avenue to change the environment?
Yeah, I'm still not, so let me take a stab at this. I don't quite know that I understand the question. So I think everyone should be involved in shaping what we have before us. And so, so like I said, as a patient, an individual, I feel like I can solve my own, to some extent. I can take my risk, and I can solve my own problems. I think the real challenge is how do we get these tools in the hands of folks who can build these tools around what their needs and values are. So that's what I don't think we see that quite yet. It's at least I haven't come across. I picture rare disease communities where they have their own data set and they have their own large language models and their own AI that they tuned, for lack of a better word. I'm not even sure, Duarte should correct me if I'm saying something wrong. It is, or not specifically not saying trained, but perhaps even trained on whatever the needs are for that group, according to their own interests. And perhaps there will be biases, and I don't necessarily think it's, bias is an inclination toward what matters to that group of people. And so, yeah, is that, am I getting to what you're saying? No.
Yeah, yes, I think so, and I'm happy to follow up in person or closer.
Yeah. Hi. Thank you for the wonderful. Sorry, is there?
Please wave.
Hey. Hi.
Oh, right there.
Yeah, there. I'm Anupriya. I'm a postdoc researcher at KTH. Thank you for the wonderful talk and sharing your lived experiences. Really appreciate that, with all the sensitivity which you brought in. I was just wondering that your lived experiences are embedded in US healthcare system, and I'm born and brought up in India. So access to healthcare, if you are from upper middle class family, is not an issue. So I was just wondering that how does that preserving patient agency would look like in healthcare system where these are not the challenges. There are limited such healthcare system, but there are nations where you can, if you have financial sources, you can reach out to doctor, to specialist, and it's just like a shopping mall where you can choose between doctors. And then we give this AI tools to the patients, which I see there is a use case of doing that. But I was just wondering, there are many cases it can backfire, and it is happening drastically. So in your, just speculating here, what do you think what would this look like in those systems?
Yeah, I'm not qualified to answer that question, but I can take a stab at it. I can say, I'm not advocating putting AI in the hands of everybody and just saying, pushing it on everybody. No, it is a tool with immense potential. And if it is right for the job, then I don't see a reason why we shouldn't use it. So it's really, each use case is different. And if it is not a problem in a different kind of health system where the values are different, then it probably shouldn't be used there. I'm not saying that it should, and so I don't think it should. It has proven useful in my case, and many folks that I know, has been a way to shift the power imbalance. But if the power imbalance in information asymmetry and all these things that make sometimes cause friction are not a problem, or are expected, or are enjoyed by the parties that are a part of it, then there's no problem to fix. So, so it's not pushing AI onto everything necessarily. What I'm saying is that what I think is people should know how to use these tools and get familiarized with them, and be able to keep that in their toolbox if it is it could be of use to them. But that's it's not for me to say.
Hi, I'm Roisin McNally from University of Melbourne. Thank you so much for your talk. It was really refreshing perspective. I work mostly in the AI and mental health space, and we know that, you know, people are using off-the-shelf AI tools for mental health support. We know that, and I do have lots of discussions with different mental health organizations and community organizations about AI, and I am a big advocate for AI. And I think the biggest challenge that we have at the moment is that there's this fear and lack of trust, and I think it links really well to Sean Munson's talk actually earlier. You know, this kind of distant threat that's kind of bubbling under the surface. But the way that we build trust in medical communities is through evidence, right? But I think we're in a catch-22 situation in that you would never be able to, you couldn't get funding or even get through an ethics procedure to be able to build the evidence in the way that, you know, so that you've got strength in the numbers to say this works for people, this is actually filling a gap in the healthcare system. So it's maybe more of an open comment to the community here and how we find better ways to kind of generate this evidence, and whether you had any thoughts from the advocacy work that you do in how this type of evidence could be generated.
Yeah, so what you're describing is, I think, slide 12. It's the AI, the lock and the key, right? It's the in your world, it's full of constraints, and I'm sorry, my world is not full of constraints in that regard, and there are many, but they're not the same constraints. I have other kinds of constraints, but to some extent, and that's what I'm saying. It's really hard for the research community and the design community to solve some of these problems because of these constraints that you are pointing out to. So I don't know, maybe there are ways to do this in a way that's more open, that it's where perhaps patients are driving it, and they are just, there is some kind of safety net underneath, so they're not smashing their face on the ground and or harming themselves. But letting people experiment and try these things, and I'm not sure how you'd fund something like this. That's the problem. I don't know. So I guess you guys are designers. I have hope that you can design around these constraints. I don't know.
Sorry, that's we're going to read online question just so that we can get this popular question answered. So the question is, the argument on democratization of medical knowledge is easy to agree with. Everyone agrees with it. But are we individualizing the problem and estranging medical experts rather than educating for collective action, as Ferre would say?
Educating for collective, can you explain that again?
Are we individualizing this problem and estranging medical experts rather than educating for collective action?
Yeah, so, medical knowledge is, I mean, there's still some places where things are behind paywalls, but information is available online, and it's up to each person to. That's why, you know, to quote Paulo Freire again, it's about you have to hold yourself to some kind of high standard in terms of education has to be available to people. People have to be able to go to school, learn things, think critically, so they can think for themselves. You know, it's a much bigger problem than I can, you know, that I can answer. There are, if you look at how the world is, a lot of times folks can't even tell sometimes the difference in social media. They're influenced by posts that are tuned for engagement. And so it's a much bigger problem. I think it's on each one of us to be able to make sense of information, learn, educate ourselves, and say, I know enough about my condition to be able to have an educated conversation with my cardiologists and cardiac electrophysiologists. This is not something I had when I was diagnosed. So people can learn. We can all learn. You have to apply yourself, and you have to make an effort, and it's not hard, and maybe communities can support and help one another. But holding back the information, or it's not an answer.
Thank you so much, Hugo. We'll finish the Q&A now. Thank you very much for coming.
Is it on? That's it. So we just want to say everything has its first, and we are really grateful to be sharing this first milestone, the first ever Interactive Health Conference with all of you here. And, thank you. And before we finish, we have one more award to give out. So, Sean.
So first, I'd like us all to give a round of applause for last night's demos. Oops, I got ahead of ourselves. Pretend you didn't see that. Right, so yeah, all of you who presented demos last night did an amazing job of giving up your time during the reception to share your work with us and engage us, and that was wonderful. I also appreciated the bonus demos during the Fraunhofer Institute tour. Thank you, that was lovely. But now, yeah, the moment we've all been waiting for, which I accidentally gave away, drum roll, our best paper, or best demo from the People's Choice is demonstrating Interactor, interoperative patient image interaction through surgical instruments. Noor, Anais, Isabel, and Ignacio, if you're here and you want to come up and get your certificates, we also have a picture if you're not, so we can clap for you. Visual. Thank you. Congrats. And then one last round of applause for all of our awardees and special recognitions. Congrats.
So we have more thanks to say. Thank you to the early conveners who started and carry on this mission that everyone has dreamed on. Thank you to everyone in the organization committee who took on this big responsibility across the world and the time zones. Thank you to the amazing student volunteers who really keeps the conference running, both in the front and back ends. Thank you to our wonderful local hosts, everyone from Harvard, Portugal, ICOS. You really make this being here even more like home.
Thank you to all our session chairs for working with us with all this experimentation, for being flexible to things that were not going as expected, and for pushing for these conversations and, yeah, driving us for a new future. Thank you. We thank very much our sponsors again. It would really not have been possible to bring so much people to the conference, for supporting so many students in this. Thank you very much. Thank you to our TPCs for aligning with us, for teaching us so many things, for being there for us. Thank you, thank you, thank you. And finally, we have general thanks to everyone that we might have been missing, to the ACs, to the reviewers, the authors, our catering, the audio, the video, the streaming, the captioning, the cleaning, everyone that has been pulling some strings for us to be here and have a great time. Thank you very much. And with everything Portuguese, we got accustomed to the metaphors and to the symbolism. And I think it's interesting for us to think about one more Portuguese concept that is interesting for you to know. So there is this bird that we call andorinha, and apparently in English it's called swallows, which is really weird. But this bird goes during the months of spring and summer here to Portugal, and because the weather gets warmer, and so they come, they do their nests, they put their eggs, and then when the weather goes colder, it goes to Africa and spends some time there until they return the next year. They are seen as a symbol of family or faithfulness because they always return to the same place, and they are traveling as a group. And we hope that all your flights go well, as for these birds, that we expect them always to come on the next year. But we also hope to see you in another Interactive Health Conference, which will be our home, so that you would return home. But also that maybe in some years you return to this first home and have a good time again. Thank you. And now...
That was so beautiful, Francisco. I don't think I can follow that. Let's hear it for these GCs. They are so incredible. Really remarkable. You set such a high bar that anyone following forevermore will have to try to meet and might not be able to. But we have a very exciting announcement for you now, and some folks who we think are up to the task. So Interactive Health 2027. So I'm going to give you a couple of, nope. You're going to be drumming for a long time here. We got some buildup, okay? So you heard me talk ad nauseum yesterday about all of the care that went into this decision, all of the deliberation that we did, and I'm going to just keep drawing that out. Okay, so the place that we're going has half of its people born in another country and 160 plus languages spoken on its street. It is home to the hospital that's ranked #2 in the world, the top publicly funded hospital anywhere. It's where the world's first cardiac pacemaker started beating. And multi-touch, right? So if we're thinking about interaction, interactive health, multi-touch was born here 22 years before the iPhone. And maybe you'll recognize this place from this video. So we're going to Toronto, and I am thrilled to introduce Jim Wallace, who is going to be the TPC. Unfortunately, our GCs had other obligations and were not able to make it here, but Jim has graciously offered to provide the sort of traditional GC introduction to the next venue. Jim.
So we are thrilled to be hosting you in Toronto. We hope to see everybody there. I will give you a few details because all of those lead-ins, all of the criteria for selecting the location, we think we've got a lot of exciting things to do in Toronto. So first of all, we'll be hosted at the University of Toronto. This is called the Myhall Centre for Engineering, Innovation and Entrepreneurship. It is one of the best universities in Canada. I'm not going to say number one. It's a really good university. Located in downtown Toronto, very central. It is foundational research in both health and technology. And so we think we've got lots of the right people right there to bring into the conference and have these amazing conversations that we've been having for the last few days. So we think it's a really great basis for that kind of conversation with health and technology all in one place. It is also very conveniently located to many, many hospitals, as you saw from the video. So this is Toronto General. UHN is one of the top-ranked hospitals in the world, top publicly funded hospital. We have access to all sorts of different healthcare facilities, healthcare professionals. We're going to try to find ways to bring them in and involve them with the conference. We're really excited about that opportunity. If you haven't been to Toronto, it is a beautiful city. I was born there. It's fantastic. We're going to be hosting the conference in the fall. So as you saw, towards October-ish, the weather should be fantastic. It won't be too hot. It won't be too cold. The leaves will be changing. And so we hope that you can come and enjoy the city. There's just so much to do. Alex and I have been talking about all the different types of food. He loves the Jamaican patties, the Greek food. I love Chinatown, Koreatown. Toronto has a little bit of everything. So as you saw, half the population was born outside of the country. We have many different languages. Canadian culture is you come and you maintain your home culture, and so you can walk down the streets and just experience a little bit of everything from across the world, including places like St. Lawrence Market, or again, all of the different food locations throughout the city. So we're hoping that you won't only come for the conference, but you can come and eat and just enjoy the place. And while I'm talking about it, there's loads of things to do near to Toronto as well. So Niagara Falls is about an hour and a half away, so it's a bit of a day trip, but if you haven't been there, it's phenomenal. You should absolutely come and check it out. If you want to get up to the, Northern Ontario, that time of year, the leaves are just breathtaking. You can do a really lovely road trip and just experience some of the Canadian wilderness just a few hours outside of Toronto. And I should pause and say that it sounds like there's going to be a lot of conferences in the area around that time of year. I don't think all of them are publicly announced yet, but Kai Play, for example, just announced they'll be in Montreal a few weeks beforehand. I believe CSCW might be there around that time. ISS is going to be on the other side of Canada in November. And so there may be reasons to come to Canada for other conferences and stick around, or maybe IH is your first stop and then you go visit them. Lots of great reasons to come to Canada. So as Jason mentioned, our general chairs are Alex Mariakakis and Aisling O'Kane. We're thrilled. We are still assembling the team. I'll have some more information on that in a second. But one of the things I wanted to do, since this is the first IH and we have a chance to establish some traditions, is to borrow a tradition that I learned about at CUI. And the tradition is that the incoming chairs provide a little bit of a thank you for some of the outgoing chairs. And so I just wanted to invite Francisco and Christina to come back up for just 1 second. And I'd love to just give them a little bit of a proper thank you. And you can trade if you like.
Thank you very much.
So this is Indigenous artwork from the Native Canadian Centre of Toronto. It's actually very close to the venue, so if you like it, you could very easily pay a visit yourself. But the tradition at CUI is to basically just give a little taste of the new venue it's really just a small token of our thanks because you've done so much in building this up, and we hope to continue building on that next year. So thank you so much.
Thank you.
Yeah. I also have sugar, a little bit of sugar, but I'll give it to you later. Yeah. Okay, so then I have two more things, and then we'll be done. The first one, and I learned this from Geraldine at the Early Career Researcher Workshop. We're going to assign homework, of course. If you would like to get involved, and you should get involved, as we said, this is the best time to be an early career researcher. It's the best time to be involved with interactive health, right? We can make this conference whatever we want it to be. And so we are looking for volunteers for every role, essentially. We would love to continue this really nice tradition of global representation, of having people of various career stages involved in the conference. So please volunteer. There are organizational committee roles. I believe we have reviewing roles for both the special issue and for all of the other tracks. Please, please, please get in touch. Let us know what you'd like to do. We'll be very eagerly reaching out to people in the next few weeks to try to get things in place as quickly as possible. But nothing is filled right now. We really do want to make sure that this is open to everyone in the community and that everyone has a chance to contribute. And I will say, we've been taking notes very actively at the town hall throughout the conference and trying to capture as much of this feedback as possible. And so please keep that coming as well. Yes, we will. I'm also the person who approves things on the mailing list, and so we will be sending this out to the mailing list. If you're not on that, we'll be trying to get it out to social media and so on, but I would also just generally appreciate it if you circulate this to all of your friends, colleagues, anybody else who might want to see this and be involved with the conference. And so this is the last slide, or the second last slide, but the other piece of homework is to figure out ways of participating, right? We want to continue all of these tracks, these wonderful tracks that we've had this year. So as you heard from Sean, there will be an upcoming call for papers for the special issue, for another special issue on transactions on health. But we expect to have all of the same tracks that we had this year. We'll be continuing to take in feedback, so there might be some new tracks, there might be small tweaks to things, but we expect to have a wide variety of ways to participate. So please keep your eyes open on that or suggest venues and submit your work so that we can share it and continue these discussions next year in Toronto. And I think... No, I think we lost. There's a really beautiful picture of Toronto on that last slide. And it says, see you in Toronto. I will wrap things up right there. We really hope to see you in Toronto next year. Thank you so much.
Yes, that was I was going to say. So. And if you want to help out move the stuff away, you're more than welcome to stay a bit.